So I'm going to run through some stuff, not hit you with too much, and really sort of hope to have more discussion at the Q&A piece. Psoriatic arthritis, beyond TNF inhibitors. So as already mentioned, it's a new world out there. There are a lot of options and a lot more coming this year, and it's becoming challenging to make some of those choices. And what I wanted to run through was a little bit of the data with some of the things that we have. The handout that you got ahead of time has way more data that I'm going to show you here because I'm just going to give you a taste of it. But then talk a bit about how you make some of those decisions. This is what we're going to focus on. This is the list of what's out there for PSA in 2021, and not really going to spend much time on the stuff in the gray, although I will start a little bit with TNF inhibitors just to set the stage, and then really talk about the other therapies that have come on behind. And here is TNF inhibitors. This is not news to anybody here, but one of the two take-home messages that when you're treating somebody's joint disease, a TNF inhibitor is a TNF inhibitor is a TNF inhibitor in psoriatic arthritis. And there really isn't much difference. The difference really only comes in probably when you start talking about skin disease, with the sense that a tanacept of the agents available probably less effective for skin disease. But for many of the people that we manage, where their joints are their primary issue, may very well be, and in most cases is sufficient. Just a nod to this study, and one of the things that we've struggled with, and before we get into other therapies, is the idea of treating people with TNF inhibitors, and where does methotrexate come in as combination or concomitant therapy? In rheumatoid arthritis, I think the stage was set very clearly that methotrexate increases response to basically all the TNF inhibitors. It's typically used as background therapy in most of our patients. Not clearly the case here, that we have a lot of people on monotherapy. We do have people in combination therapy, and this is the one study that actually looked at that. All the other studies in psoriatic arthritis have people who are on methotrexate or not, but they came into the study on methotrexate or not. We really don't know what value the methotrexate adds to their care. In this case, this is the SEAM PSA study where patients were randomized to methotrexate or etanercept or the combination, and the take-home here was that the combination didn't really lead to any more significant response than just the etanercept alone. Is this something you can extrapolate to all TNF inhibitors? Is this the same story with adalimumab? Is it the same story with infliximab? We don't know. There's anecdotal evidence that perhaps you get more mileage out of concomitant therapy in some of the monoclonal antibodies, but we simply don't know. And that's all I'm going to say about TNF, so we're going to move on to some of the other drugs. So here's the key sort of cartoon for this talk and for this disease, and that is the importance of the IL-17 pathway in psoriatic disease, and in fact in spondyloarthritic disease in general. This is not a cartoon I would show you for rheumatoid arthritis, because it turns out the IL-17 inhibitors have failed miserably in rheumatoid arthritis because this pathway isn't hugely responsible for the joint disease. We'll go through a lot of these, but it really focuses on the importance of the Th17 cell that drives a lot of the skin disease particularly, and as it turns out, a lot of the joint disease, the enthesitis, and even the axial disease, as we'll talk about. So the first drug that came along after a TNF inhibitor was a drug called ustekinumab. This was an antibody that targeted interleukin-12 and interleukin-23. It was not intended to target interleukin-12 and interleukin-23. Interleukin-23 was really the goal for this drug. The problem was that the antibody they had picked a subunit, or targeted a subunit, a specific subunit on interleukin-23 that also appears in interleukin-12. And that was really not the goal in the front at the beginning of this. The goal was really to block interleukin-23, but it turns out that P40 subunit that's the target for this antibody is a component of both IL-12 and IL-23, and so you get inhibition of both, which, as it turns out, may not have been the best idea, or at least the most successful approach, because one might think that you block multiple cytokines and you're going to get even better response in terms of disease activity, but as it turns out, blocking IL-12 may actually abrogate some of the response to inhibiting IL-23, and as I'll show you a little bit down the road, some of the data that's been showing up with pure IL-23 inhibitors actually, at least for joint disease, and probably to a certain extent for skin disease, is more successful than blocking both cytokines. But here's the data that we had with ustekinumab, and for those of you and for those of us who have been treating psoriatic arthritis for a while, we're kind of familiar with this data in clinic because this was never a drug that we jumped all over, and for a couple of reasons. So if you look at the ACR20 responses, it is okay. It's certainly better than placebo, but it's not at the kind of level that we were looking for and had seen previously with TNF inhibitors, nor at the level that we see with interleukin-17 inhibitors, as I'll come up to next. And in particular, in the patients who'd failed TNF inhibitors, who'd previously been exposed to a TNF inhibitor, the response wasn't great. And that's a challenge because when this drug first came out, that was the space it was getting used in, and it's being used in patients who had failed the TNF, and it turned out it was not all that successful. The dermatologists loved this drug from the beginning because for skin disease, this was a phenomenal drug. It did a great job at managing skin disease. They could take an injection every 3 months and manage their skin disease. So they loved it from the outset, and they began to put a lot of patients on ustekinumab. And I don't know about you guys, but we started to see many of them whose joints suddenly were an issue for them and hadn't been before, whatever else they'd previously been taking. Okay. Next step down the line in that whole sort of Th17, IL-17 pathway is IL-17. And it turns out inhibition of IL-17 has been very successful, both for the dermatologists at managing the skin disease and for us at managing the rheumatologic disease. And I'm not going to worry about having you sort of look at all the details on this. Suffice it to say, if you look at the graphs on the left, this is with secukinumab, either of the two higher doses of secukinumab, either 150 milligrams every 4 weeks or 30 milligrams every 300 milligrams every 4 weeks, gives you the kind of clinical joint response at an ACR20 or an ACR50 response level that we are used to seeing with TNF inhibitors in psoriatic arthritis. When this drug came out for dermatologists, they had some of the same data. They almost always used 300 milligrams instead of 150 milligrams. Rheumatologists, I don't know whether we're more cautious by nature or what was the story, but a lot of patients ended up on 150 from the beginning. And I'm not sure there's any value to that because the 300 milligram dose is quite effective and there's no safety differential between the two. And then the other IL-17 inhibitor that we have is ixekizumab, and this is one of the pivotal studies with ixekizumab. Again, not worried about all the details in the data, except just to point out that at a couple of different dose options, either given every 2 weeks or every 4 weeks, which is really the commercial dose that we're using now, the response rates were quite good, as you see there over on the left. And again, in that same level of response that we were used to seeing with TNF inhibitors. And then again, just like with secukinumab and frankly with ustekinumab for the dermatologist, the skin responses really good. So PASI 75 is a 75% improvement in their composite skin index. That's the benchmark that they have to achieve to get FDA approval for a drug in psoriasis. They have a little higher bar than we have, so they need to achieve 75% approval as opposed to 20% improvement as we see with an ACR20. But you can see the numbers, and pretty dramatic. And in particular, look at these numbers here. PASI 100. What's a PASI 100? It means their skin disease is all better. There's no psoriasis. 50% of the patients. So these drugs, these IL-17 inhibitors, very effective for skin disease and comparable for joint disease. Okay, couple of cautionary notes, something to just be aware of. It doesn't change what you do, but IL-17 turns out to be important in how we handle candidal infections. And so in every single trial with an IL-17 inhibitor, handful of patients with thrush, with vaginal candidiasis, occasional esophageal candidiasis, no systemic disease, and most of it was fairly easily managed without stopping the underlying drug, which is something to be aware of as you're using this drug in your patients. And then the inflammatory bowel disease has been an unresolved issue. And this all stems from an early trial of secukinumab in Crohn's disease, in which there was at least a hint that perhaps the patients who were treated did worse than the placebo patients, at least by one measure of response. Now, the gastroenterologists say that wasn't the best measure of response. They're not convinced that that was real. And we just don't know. And so we've seen patients who've developed inflammatory bowel disease while on IL-17 inhibitors. We've seen patients whose inflammatory bowel disease has gotten worse. But it's complicated by the fact that there's a genetic link here, and our patients with psoriasis and psoriatic arthritis get IBD. And it's really difficult to know. And so I think that where we've landed on this is that if you have a patient, certainly if you have a patient who has had recently active inflammatory bowel disease, I would be pretty hesitant just because of the noise that's out there about this pathway. But I wouldn't necessarily worry if a patient said, I have a sibling or parent with IBD, because genetically that's what you expect to see in this space in our patients with spondyloarthritis and psoriatic arthritis in general. Okay. And then the next biologic step up, if you will, for the dermatologist has been the IL-23 inhibitors. And I was intrigued to hear Clay say, you know, they're going right to biologics because it's easy to get them approved. I don't know. I mean, I think the dermatologists live in a different land than we do as rheumatologists, because it's really hard. And it's interesting, even in the same location, I hear from our dermatologists in Chicago, it's a heck of a lot easier for them to get a biologic approved for some reason than it is for us. And I have no idea where that's coming from. But they have really jumped in feet first into the IL-23 inhibitors. These are drugs that target not that P40 subunit that also picks up IL-12, but the P19 subunit of the IL-23 molecule, which is unique and specific to interleukin-23. And so if you have an antibody that's targeted against that P19 subunit, then it's an antibody that only blocks interleukin-23 signaling and doesn't touch IL-12. And from a skin perspective, these are the agents that have given them the best response by far of any of the biologics they've been using in psoriasis. And the dermatologists for people with bad skin disease have really moved into these. And the other advantage has been the infrequency of dosing, every 2 months or every 3 months, depending on the drug, the very low risk of toxicity. And it seems, although we don't have really great data, but it seems that as we've moved from TNF inhibitors to IL-17 inhibitors to IL-23 inhibitors, that the risk of serious infection has gone down meaningfully with each improvement, at least in terms of managing the skin disease. Now, it's a little complicated in the derm space because their patients don't get the number of serious infections that our patients with inflammatory arthritis get. But still, they've really sort of moved into this space. And we have our first drug. And so guselkumab, approved last year for psoriatic arthritis, based on 2 studies that I'll show you here, Discover 1 and then Discover 2. So these are patients who were treated with guselkumab at one of 2 doses, and the yellow line there is the commercial dose. That's the dose that had previously been approved for psoriasis. So it's every 8 weeks, single injection, sub-Q injection every 8 weeks, 100 milligrams. And you see the response rates compared to placebo, similar to what we've seen with any of the other biologics. And when you look at the skin response, again, pretty dramatic skin response. So you're talking about 75 to 85% of patients achieving that 75% improvement in skin disease, which is kind of the benchmark for psoriasis. The other interesting thing with this drug was that it seemed to work both in TNF exposed patients and those who weren't. And this was the data from that study. So that study had about up to 40% of patients who'd seen a TNF before. I don't think it was quite 40% at the end of the trial, but it was somewhere in the high 30s. And when they broke them down to patients who had previously seen or not seen a TNF, response was the same. Different than what had been seen previously with ustekinumab. Remember that IL-12/23 targeting antibody. So it gives us an option for those patients who've been on a TNF. This drug seems to work equally as well as those who haven't. Coming down after that are other drugs. Risankizumab, this caught a lot of attention. This is another IL-23 specific inhibitor. And this got a lot of attention for the phase 2 study. If you look at the data on the right, I'll call out the very light pink bars. Okay. The dermatology dose for psoriasis is 150 milligrams every 3 months. after a loading dose. So they get one, and then at a month, and then a loading dose every 3 months. The light pink bars, 75 milligrams once. And they still got a response that was significantly better than placebo for skin response, and at least appeared to be pretty significant for joint response. All right? So there were a lot of hope. There was a lot of hope about this drug and where this is going to pan out. They've now gone into phase 3. This is data straight out of a press release because it hasn't been published, even in abstract, hasn't been presented even in abstract form. But out of the press release, it's not as impressive as we might have hoped. So they have 2 concurrent phase 3 trials going on, Keepsake 1 and Keepsake 2. Don't even ask me what those acronyms stand for, but they're pretty good. And if you look at the response relative to placebo, the ACR 20 response, not bad at 57%, but the placebo response 34%. So the differential isn't tremendous. So this didn't turn out to be quite as exciting and as effective as we might have hoped. We'll have to see. We haven't seen the full data set from this. It does look like it worked pretty well for the skin disease because you see 50+% PASI 90 response, 90% improvement with very little placebo response. So it is pretty good for skin disease. So we'll see where it is, where it gets to. There's a third IL-23 inhibitor that the dermatologists are using called tildrakizumab, which also looked good in phase 2. We don't have any phase 3 data yet in psoriatic arthritis. But I think that these drugs will come into play as we move forward. And with that, actually, I want to get into our first question. Artie, you're in charge of the iPad, I guess. So you have a 42-year-old patient with psoriatic arthritis, bad psoriasis. She's been on methotrexate, isn't doing well. She's got tendinitis, a swollen wrist, and bad foot pain, but her skin disease is her biggest problem. What would you recommend next?
All right, so we have the results is just a little bit of wobble. IL-17 is in the lead. IL-23 is catching up. Here comes TNF inhibitor in the corner. It looks like 52% IL-17, 26% 23, 19% TNF inhibitor, only 3% of JAK inhibitor.
I actually think that either of those first 2 are reasonable options. I mean, I think if you have a patient with skin disease, it's really driving a lot of your decision making. It makes a ton of sense to use either an IL-17 or an IL-23 inhibitor. And I think right now, because of the clinical experience that we have with an IL-17 inhibitors, that's probably a more sure bet than an IL-23 inhibitor, at least in terms of managing her joint disease. I think it wouldn't be wrong to use an IL-23, but I think you've got either option, and nobody would fault you either way. But I'm not surprised that most people, given our experience, would have gone with an IL-17 inhibitor. Okay, so speaking of that, how do we know, and how do we make these comparisons? Well, finally, we have a couple of head-to-head trials that help us a little bit in this space. Here's the Spirit head-to-head, H2H, and this is ixekizumab versus adalimumab, okay? Couple of caveats to this trial. This is an open-label trial. The assessors were blinded, but patients knew they were getting adalimumab or ixekizumab. They were randomized 1-to-1. Some were on background methotrexate. They were not required to be, but about half of the patients in both arms, which is kind of what you see in a psoriatic arthritis trial. The primary endpoint was a primary endpoint that had not been used before, nor validated before, frankly, and it was patients had to improve both skin and joints. So the primary endpoint was 50% improvement in skin disease and joint disease is measured by an ACR 50, and 100% resolution of skin disease as measured by a PASI 100. And you can see, if you look at that primary endpoint, that ixekizumab was superior to adalimumab in this study. When you break it down to joints versus skin, it's not surprising. The joint response was about the same. It was the skin response that really drove that differential. And that's not surprising at all, as we know that the IL-17 inhibitors do a better job of controlling the skin disease than the TNF inhibitors. The other head-to-head that we now have is the Succeed trial. This is secukinumab versus adalimumab. This was a blinded study, and they used the ACR 20 response as their primary endpoint. So they did not look at a primary endpoint that was skin and joints, but just the joints. And they actually powered this study hoping to show that secukinumab was actually more effective than adalimumab for joint disease. And they didn't show it. Here's the primary endpoint, and they didn't quite achieve statistical significance. Interestingly, they used a statistical analysis that didn't achieve significance. Had they used a more traditional analysis that is used in most of the trials we see, which is a non-responder imputation, they actually would have seen a slight difference between secukinumab and adalimumab in favor of the secukinumab. Skin disease responded much better to secukinumab in this study than to adalimumab, so it ended up showing a lot of the same stuff that the ixekizumab trial showed, which is that fairly equivalent for joint disease, but superiority for skin disease with IL-17 inhibitors, which harkens back to that patient we just saw. All right, one other issue that comes up. Psoriatic arthritis is associated with axial disease, okay? If you go way back to the Mullen-Wright criteria, like 5% of people had primarily axial disease. But if you look at the numbers from cohorts that are out there now, probably 40% of people with psoriatic arthritis have some degree of inflammatory spine involvement. So now you've got your 42-year-old patient who has severe back pain and stiffness. He's getting light therapy for his skin disease. He's on an NSAID that's pretty much controlling his hand pain that he has, but it's his back pain that is his big problem. What would you recommend next for this guy?
All right, survey says we're up in the high 60s, 80 responders. Do I hear 90? 90, 99.
100?
111,
Yes!
All right. And actually, with all the additions, not changing much. 71% TNF inhibitor, 23% IL-17 with 4 for a 23 and 2 for a JAK inhibitor.
Okay. So, again, no right answer here, but I put this up for a reason, and that is to think about, as we manage our patients, which drugs work for which components of disease, and it's very clear that TNF inhibitors work for the axial disease. We know that because they're approved for AS and non-radiographic axSpA. Same thing with IL-17 inhibitors. What about the IL-23 inhibitors? Where are they going to come in for spine disease? Well, I put this up because I wanted to bring up a cautionary note, okay? So here we have some data from the one study in psoriatic arthritis that specifically looked at patients with axial disease. This is the Maximize study with secukinumab, and it showed that, again, both of the two doses that are out there for secukinumab, either 300 or 150 milligrams every 4 weeks, were effective for overall response, but also worked for the back disease in patients who had significant back involvement with their psoriatic arthritis. And then we have this study, and this is a post hoc analysis of the guselkumab study that I showed you before, and this is a combined look at the Discover 1 and 2, which were the two pivotal studies they did with guselkumab, and they looked at the patients who had spondylitis based on historical x-rays or what the investigator or the treating physician said. And if you look there on the left, it looks like they did pretty well. Right? Their BASDAI scores improved significantly relative to placebo. The question on the BASDAI questionnaire that asked specifically about spinal pain improved. Okay? The percentage of patients who achieved a 50% improvement in BASDAI scores improved. Great drug for axial disease, right? Be careful. This came out of the ACR meeting just this past year, and I bring this up as a cautionary note as we're starting to think about axial disease. And this was from a completely different cohort, but they looked at a bunch of patients with psoriatic arthritis who were about to start a biologic therapy. And they administered the BASDAI scoring, the BASDAI questionnaire to all of them, both to patients who had purely peripheral disease with no spine involvement at all, and patients who had both axial and peripheral disease. And lo and behold, at baseline, their BASDAI scores were comparable. And when they looked at who improved with TNF inhibitor or IL-17 inhibitors, it was about the same whether they had peripheral disease or both axial and peripheral disease, even in the patients who supposedly had more axial involvement, including that question 2, which is axial pain. All right? So the takeaway from this one is that the BASDA score and a lot of the composite scores that we use to look at axial disease probably pick up more overall joint disease and maybe picking up overall joint disease. So I'd be very cautious in a trial when you see those kind of data from assuming that that means that the drug is definitely good for the axial disease, because it may just be picking up overall improvement. I'm not saying that IL-23 inhibitors aren't great. They work very well for joint disease. It's not clear that they're working specifically for the axial disease. Okay, last little bit here, targeted small molecules, JAK inhibitors. You know the story. Cytokines signal through surface receptors. They phosphorylate a JAK dimer at the base there. That in turn phosphorylates these STAT proteins that go down and initiate transcription at the nucleus. First drug that we saw, tofacitinib. Okay, we've used this for rheumatoid arthritis for getting close to 10 years now. And on the left there, you see tofacitinib at either the lower dose, 5 milligrams BID, or the higher dose that we don't use anymore at all, 10 milligrams BID. Drug was effective for joint disease. Key point, though, skin response in that bottom bullet wasn't great. Okay? In the population of patients who'd been on a TNF before, again, both doses with efficacy for joint disease, but the skin response actually was not significantly better than placebo at the 5 milligram BID dose, the dose that we use commercially. Okay? So another option in psoriatic arthritis, but I think the hesitancy that people appropriately had after seeing this was, is this drug going to deal with the skin aspect of my patients as well, because that's an integral part of their disease. And then we got this trial. This is upadacitinib that we've now had for rheumatoid arthritis for a few years. This is one of two studies they did with upadacitinib in psoriatic arthritis. In this one, they used adalimumab as an active comparator arm. It was not, and actually was powered to compare upadacitinib to adalimumab for non-inferiority, and it turned out that upadacitinib was as good as adalimumab for joints and for skin disease, if you look down there in the bottom left. And there you see skin responses that are pretty significant, more than we're seeing with tofacitinib. And so I think this is the first place that we have a small molecule that may actually offer the advantages of treating both the joint and the skin disease in psoriatic arthritis that's comparable to what we've seen with biologic therapies. This is just the second study. These are the patients who had not yet seen, who'd failed a biologic DMARD. And again, pretty decent response even in this population, and again with skin disease too. So the differential here is that there's both joint and skin response. And then I'm just going to highlight what may be coming, and this is a drug called deucravacitinib. This is a JAK inhibitor that targets TYK2, which is kind of JAK4. It's the fourth molecule in the JAK family. Why it was named TYK2 and not JAK4 in the first place, I have no idea, but such as it is. And here are the ACR responses. The key point to this drug is that it appears that IL-17 may signal through TYK2. And so this may be sort of a relatively targeted JAK inhibitor that targets that particular pathway that's so important in spinal arthritis. Although when you look at the joint responses, not very much, not superbly better than we've seen. And the skin responses, too, don't look like they're dramatically better than what we've seen with some of the other biologics. But yet to be seen. This is just phase 2 data. We'll see what comes up. So last question, and there's obviously no right answer to this, but just curious what people think about. When you're managing your psoriatic arthritis patients, where's your role? Are you focused on just managing the joint symptoms and you let the dermatologist worry about the skin disease? Do you work with a dermatologist to manage the skin disease, or do you manage both?
The answers keep coming in here. All right, we're above 100, topping out at 120. And they keep coming in. But 55%, I manage both the skin and the joints. 41% focusing on the joint. I work with a dermatologist. And 5% focused on managing joint, the psoriasis is the dermatologist problem.
Interesting. I actually, that's more managing both than I would have thought, and I suspect that that speaks to sort of where you practice and whether you have medical dermatologists or the dermatologists in your area are really focused on acne and cosmetics. In our space, it's really helpful to have medical dermatologists who can help work with us on the skin disease. I put this question up just to lead into the last 2 seconds here on the talk, and that's treatment recommendations. Alan gave you a nice talk this morning on treatment recommendations for rheumatoid arthritis, bunch of recommendations out there for psoriatic arthritis. The challenge with psoriatic arthritis is that it's a multifaceted disease, and so you can't have recommendations that just focus on managing the joint disease as if the skin disease or the nail disease don't exist. And so the GRAPPA group, which is both rheumatologists and dermatologists, sort of took the lead on this a few years back with a first set of recommendation that really sort of focused on breaking the disease into the different aspects of disease and then looking at which treatments worked on those diseases. Okay? Rather than being a cookbook where you've got a set of recipes, like this is how you treat somebody with psoriatic arthritis, I think that this sort of looked at us as chefs who know what the heck we're doing and really sort of said, well, here are some ingredients that may work depending on the situation that you're working with, and let us figure out our own recipe. And I think it gives us some useful information. The second iteration got way more complicated because we've got way more drugs and way more options, but the same idea, and the same idea to say, you have a patient with psoriatic disease in front of you, which are the aspects of the disease that are the problem for that patient and which drugs are going to deal with that, and then you come down to a therapy that's the right therapy for them. And the third iteration is in the works right now. Will be coming sometime in the next 6 months. Probably we'll see hints of it, but it's just added more drugs. Same approach again, and I think that's a very useful approach. So I'll wrap it up here. We've got new biologic and synthetic agents for both skin and joint disease. I think for the dermatologist, there's been a very clear path with improvement in skin response with each new agent that they've had, with each new target that they've come up with. We really haven't seen that in joint disease, and at best we've seen parity, and these newer biologics are as good as TNF inhibitors for joint disease, but nothing has been better so far. It is nice that we finally have oral agents that give us an option in those patients. We have very little good data on head-to-head therapies. We absolutely need head-to-head studies to try to figure out how to pick and choose between the drugs that we have. And the last thing is the multiple manifestations of disease make it really important to consider these patients and all the different pieces that go into it. It's a little different than rheumatoid arthritis where you're focused just on joints. Here you've got a lot of different aspects that you need to worry about as you're choosing therapies. And with that, I'll leave you and turn it over to the next speaker.
All right.